Hello everyone. I am Dr. Srijana, Senior Lecturer, Department of Conservative Dentistry and Endodontics, SRM Dental College, Ramapuram. Today, I will be talking about CT, that is computed tomography in endodontics. To keep it a little simple, I have drawn a mind map for you all. I shall be sharing the mind map with you all. So, why do you think we need a three-dimensional radiographic assessment of teeth and the surrounding structures? Well, whatever initially radiographs are being taken, they failed to give us the important data. It was basically Alan Cormack and Hounsfield in the year 1972 who introduced CT, that is computed tomography. Now, why is it better than the 2D type of radiographs? It is because this gives us a detailed information of the same, the teeth and the surrounding areas. Now, these basically give us a computerized X-ray images in which the source of X-ray will be put on the patient. The patient is stagnant, and these X-rays will quickly rotate, producing thin slices of images. Now, these images, when they get superimposed upon one another, that will fetch us the computerized X-ray images, which will give us a further idea of what we need to do. So now, based on the detector element and its position, there are a few generations of CT. These are basically four: first, second, third, and fourth. The first generation basically has a single detector element, and the X-ray beam is like a pencil. So there is rotation and translation that will be occurring. Next, in the second generation, there is a fan beam scanning device. So it has basically more than one detectors, and these are located on the opposite sides of the object. The third is a large arc-shaped detector. There is basically no need for translation for the third generation, and there is only rotation that will be happening in this particular generation. And the fourth, in the fourth generation, there's basically an entire circle of detectors, and the static detector is basically present with a rotating X-ray tube. So in the first, second, and third generations of computed tomography devices, it is basically the X-ray beam, the source of the X-ray, that will be rotating. However, in the fourth generation, it is the reverse. Now, why do you think do we need CT in dentistry? It is basically to evaluate trauma, tumors, cysts, bone abnormalities, paranasal sinusitis, TMJ disorders, neck infections or abscesses, and even to plan for the implants. Now, why do we need CT in endodontics? Basically, the different type of CT or computed tomography that can be used for endodontics are micro CT, spiral CT, PQCT, and CBCT, amongst which CBCT, which is cone beam computed tomography, is used in the maximum level. Now, micro CT is basically not used much because of increased radiation. The slice that is produced by micro CT is basically 600 micrometers. Then comes the spiral CT. The spiral CT has a slice of 650 to 1000 micrometers. In this, the X-ray source is continuously rotating, and the X-ray source with continuous rotation, and the data will be assembled and it is translated instantly. Next comes PQCT. PQCT gives us thin slices, which is about 250 microns. There is a presence of semiconductor crystals in the detectors, and the X-ray tube is present with a very minute focal spot. Next comes the hero of CT machines, which is CBCT. Now, in this cone beam computed tomography, there is basically a cone beam source of radiation that has a very good effect because of the presence of different type of slices that can be seen. So starting from 80 to 200 microns, you can have the slicing of the images. Now, based on the field of view, there can be three different types, which is short, that is 10 centimeters, medium, 10 to 15 centimeters, and 15 to 23, that is the large area of focal. Now, coming to the uses of the CBCT in endodontics, it is basically used to analyze the root canal anatomy. Root canal anatomy, even with the presence of 2D imaging, does not exactly tell us what type or what Bertucci's classification or how difficult or easy the particular case is going to be. To be able to understand that better, CBCT gives us a better idea. At which extent is the canal bifurcating? Are there more than 2 canals? Are there more than 4 canals? Do these canals have a separate exit, or are they merging ultimately and exiting through the apical foramen? All of this information we can find in the CBCT analysis. Next comes the assessment of root canal preparation. With so many new materials being introduced, so many different types of file systems being introduced, it is a little difficult for us to conduct research when it comes to directly onto the patients. Basically, it is not even ethical. Hence, for the assessment of the root canal preparation in the in vitro models, CBCT helps us a lot. It helps us to check for the way that we have cut the dentine or the amount of dentine that is basically present preoperatively and postoperatively. The preoperative and postoperative images will be superimposed. And finally, we will get our answer of how well or how cleanly or how neatly the canals have been enlarged. Next is the detection of periradicular lesions. Now, there are certain cases where even the diagnostician would be a little confused, thinking if this is a periradicular lesion, if it is a periradicular lesion, what is the nature of the periradicular lesion? The amount of radiolucency up to 30% decalcification is not seen on our regular radiographs. Hence, here we have an edge over the regular radiographs when we are using our CBCT machines. For pre-surgical assessment in cases of pulp obliterations, in cases where you need to technically think of how to go ahead with the case, either surgical or even a routine endodontic treatment, the CBCT comes into action. For diagnosing a resorption, the type of resorption, the location of resorption, the extent of resorption, and to even plan for the treatment of management of such internal and external resorption, CBCT helps us to diagnose the trauma. If there are multiple traumas occurring in the multiple planes across the face, across the maxillofacial region, then definitely CBCT comes into play. In this, a larger FOV CBCT can be taken. And to detect vertical root fractures. Now, vertical root fractures are definitely a different case. It is very difficult for any diagnostician, for any endodontist to find it based on just a routine radiographic examination. Hence, in this, with extreme thin slice sections, it is very much possible for us to see the vertical root fractures. I hope you all came to know a bit of the CT and CBCT in endodontics. Thank you.